we've never actually
I'm just
had
like,
a
yeah.
conversation. And I'm such a fan of
Yeah.
yours. You're so smart.
Oh, and I'm obviously a huge fan of yours as well. So,
Well, if you're still a
I
fan of
feel
mine at the end
that
of this week, that's a
we,
shock.
oh my goodness. I don't want to say that everyone's been in that position, but I would say that anyone in my profession
Yeah,
has been in a similar position. Is my network okay?
it's lagging. It's slow.
Okay. Because
We
I
have,
think I'm just cutting in and out. It's probably my,
you are.
yeah, it's probably my, I have a green light, but it might be that that is like trying to use Wi-Fi and not.
Well, you're all the way in Canada. But I don't want to end up talking over you. So can you connect to something that is, she's coming back. Okay. Hi, Jesse. I want to make
Yeah.
sure that
Is
I
that
don't, go ahead.
is that better?
It is at the moment.
Is that better?
Yeah, it seems to be.
Okay. Hopefully it stays that way.
I
Okay.
hope so.
I have a green light at the top, and I just basically was like, I think I was just jumping on and off of the Wi-Fi. So,
Yeah, I just don't want to interrupt you when you're speaking because if it's a lag because I have the habit of doing that by accident anyway. But can you hear me clearly?
I can.
Okay. So I want to just start out by saying to everyone who's watching that I think this is a big conversation, and I know it's something you're all very interested in, but I think out of respect to Dr. Serena, that we have to remember that she can't analyze or diagnose anyone's individual dogs. So we need to try to keep the questions in broad categories. And what I mean by that is like, not my dog does this, my dog does that, but more like, how do you address certain problems? Does that work for you, Dr. Serena? Uh-oh.
Yes. So obviously, maybe I should move spots.
Okay. Okay. Yeah. You think it'll get better?
E- just one moment.
Take your time. Does everybody understand what I'm saying? Like, I don't want to weigh her down with, can I sneak in a free diagnosis? Not free, but like I need information. So what I want you guys to try to do is let's give her a chance to talk. And then we'll do hi, Melissa. And then we'll do questions, but I want to try to ask them. I think I know a lot of what you guys may want to know, but if I'm not hitting that, then, and if you type something into the questions and I don't see it, because sometimes 25, 30 messages come at once, then just beautiful. I am a disaster area, but thank you, Carrie. Then just type it again and I'll try to, find it and go through all of it. Maybe she decided she doesn't want to talk about it. But there you are. Okay.
I just
Hi.
moved inside.
I can see.
Is
So,
it better?
I, oh my God. It was.
It's like
It was
all
pausing. It was pausing. Now let's
it's
hope. Okay.
pausing. Is there a leg?
A leg?
Is there?
I don't know. A lag. Oh, a lag. I thought you said, is there a leg? There's two legs or four.
We're talking about the four-legged ones. I
Yeah,
think it's good right now.
I think so
I,
too.
okay, okay, good.
So I was really, let me get the ball rolling. And I've given
Yes.
everybody their marching orders to ask questions in broad categories, and not
Hmm.
try to get you to personally diagnose their animals. But I think part of the things that I'm seeing as broader topics for this conversation, and of course you can determine what it is you feel you want to go into. But I think I know my audience has become much more savvy about behavior meds in the last year or so. It's something I've covered a lot.
Hmm.
Dr. Forbes and I have done lives on behavior meds. We do try to
Nice.
speak in like whispers so the live doesn't get flagged by TikTok for talking about things that we're not supposed to talk about, like pharmaceuticals. So I
Mm,
usually will abbreviate Traz, GABA, things like that instead of
I
saying the
see.
full name of medication. Um,
Right.
I think I think starting off, here are some of the things that I'm thinking about. My thoughts run to there seems to be a shift from what was conventionally prescribed by vets who don't are not necessarily savvy about behavior, with sort of a broad generic application of this like TRAS for every behavior problem. And I think we've gotten away from that, but people are often dealing with vets who don't know as much as we'd like them to, and they cannot ascertain what is best for their animal based on the behavior challenges.
Hmm.
I also think that there's a lot of confusion around what we can expect anything to do for our dogs, particularly if it's not dovetailed with behavior modification. So they always have to go hand in hand. So my questions to you to start with would be the video that you made for me or an answer to me
Yeah.
really did a deeper dive into how the brain works with SSRIs and the immediate uptake or response to an SSRI, and then the long term application or what we see, and then some of the other meds that people are starting to prescribe that weren't really used in the past. Clonidine. Okay, things like newer things that are being added. Why don't we start with what you described for me in terms of when you start a dog on an SSRI? Do you want to start there? Someone?
As in, like the reasons why I might, or
Well, that's a super good topic, but I thought I wanted you to address what you did in your video, which is like I started Maya on fluoxetine and the next day her aggression towards me stopped. And
right.
you were talking about the fact that because we always hear it takes 5 weeks to start working, and you were explaining to me that part.
Hmm. Yeah, and I didn't watch all of your live when you kind of explained the reasons that you came to your decision regarding Maya. But I did hear that you had started her on a low dose of medication. But you had also had her on seizure medication too, I believe.
Correct.
So when you started her on the SSRI and you saw an immediate change, it's because of that increase in serotonin. You get a decrease in anxiety at that point. And that tends to be the side effect of the medication in the sense that it's not the true effect of the medication. And so anything that happens within the first 3 to 4 days is your side effect. And if we see a beneficial effect, and then that beneficial effect reduces after, 3, 4, 5 weeks, that's when we say maybe the dose needs to be adjusted at that stage. And so reassessing at that like 6 week mark is usually what I suggest is like we've gone through that stage where the receptors are remodeling in the brain. We get The initial increase in serotonin is because of the blockage of the serotonin reuptake inhibitor on the presynaptic neuron. And then because there's more serotonin in that synapse, the
And excuse,
post.
let me just, because we're not medical people,
Mhm.
are you, and I want to make sure everybody feels like they understand. So I'm trying to human speak it.
Of course.
Not that you're not, but like
Yeah.
we don't necessarily know what you're describing. So would I be correct
Hmm.
in saying, understanding from what you're saying, that there is going to be an initial boost due to the uh, blocking of the serotonin being sort of drained from the neurons or the synapses, and then over time it sort of like fills in the space between and becomes part of the more permanent house of the brain? Would that
So
be
if
a
if this
ridiculous way to
is
say?
if this is the like presynaptic neuron, the synapse is the tiny space between the two neurons. So
That's what I
this
was
is going to
trying
be
to say
your
and didn't
this
do
is going
well.
to be your like synapse.
Okay.
There that on the presynaptic neuron. So this let's say this neuron releases serotonin,
Okay.
and it would release serotonin into the synapse, the space between. And
Okay.
then it binds to the receptors on the postsynaptic neuron. So the synapse is the space between. And then what happens is if we have dysregulation of serotonin, we just don't have enough serotonin in the brain. We have our little synapse here. We add an SSRI, so that's a selective serotonin reuptake inhibitor. So serotonin reuptake inhibitor. So inhibitor, we're going to block. The reuptake uh, transporter is on the presynaptic neuron. So that's
Okay.
on this side. And we enter our little SSRI and it blocks that. And the reuptake is actually the amount of serotonin in the synapse. It can't go back in here. So
Oh,
it's,
that's so interesting. That's what the reuptake inhibitor means.
yeah.
Oh, you did that so well. Okay.
So here we are now
Yes.
because this neuron can't take it back in, it stays here longer. So it's not producing more serotonin, it's increasing the effect of the serotonin by leaving it in the synapse longer
Okay.
so
Got
that
it.
it can bind to this one
Okay.
and actually signal to the rest of the brain, hey, we don't need to be so hypervigilant. Hey, like we can recover faster. Hey, like maybe we can sleep a little bit better because we're not constantly thinking about bad things might happen in our environment. And so if we have this one constantly firing, then this one says, why are we firing so much? And the receptors on here, which are the 5-HT2A receptors on this side, it says there's too many receptors here. So it starts enveloping them and sucking them into the cell on this side so that there's actually fewer receptors. And that's why you get later on, it seems like there's less serotonin and there's less binding on this one. But the goal is to overall increase the function of this neuron on this side. And later, the serotonin here actually starts to go backwards and by diffusion goes over to the end on this end, basically where the body of the neuron is, and causes the receptors on this one, which are autoreceptors, that negative feedback to turn itself off. It communicates to those receptors. And so it's very complicated in that sense.
It's very complicated. It is. It's very
Hmm.
complicated, and the wheels are turning in my head because as this any what a process, right? I know as it relates to behavior, it's almost like now. the firing off in my brain right now is not going to make it to my mouth in a sentence that makes sense. But because that neural activity is so complicated, between what's the appropriate dose, whether or not are we getting something that's balanced enough that there's the ability to learn? Because if we're going to do behavior modification, we need a canvas to paint. So and because there is that initial potential for fatigue, lack of appetite, all the things that go with the body learning to metabolize something new,
Mm-hmm.
it's very hard to get a sense of what's actually happening inside the brain as it relates to behavior. So
Mm-hmm.
I've had this very interesting experience in the past with one of my dogs, Benito, was before Jude, who would bite me all the time, right? Like,
Mm-hmm.
but it wasn't like I want to hurt you. It was more this like frenzy. You could literally see his brain short circuiting.
Mm-hmm.
20 milligrams of fluoxetine. He would bite me 3 times. 1, 2, 3, just by asking him to like say hello to me, right? Anything was too much.
Mm-hmm.
20 milligrams of fluoxetine, he'd start biting just twice. 40 milligrams of fluoxetine, he'd bite once. 60 milligrams of fluoxetine for that dog. And I could literally see his brain go, yeah, I don't need to do that.
Yeah.
So, but I was looking for something. Now, I don't think that most people know what they're looking for.
Right.
So if we have a pet parent whose dog is struggling with their, but like, let's say, thank you, that the dog has really bad separation anxiety. I personally try to stay away from heavy sedation because I want to build skill and I need
Mm-hmm.
cognitive function.
Yeah.
So, how do you determine like, I'm sure for you on your side of things, it's hard to find people who are doing something that's effective in behavior modification to couple with the medical end unless you're doing it yourself.
Right.
So I think there's this like big drop off between what people like you do and what people like I do, and finding practitioners who are smart enough to either collaborate or understand what the problem is and how do we guide pet parents as to what the questions to ask are. Or
Right.
do you know where I'm going with this? Like,
Yeah.
I
So
want
if
to
you,
help people and I don't know how.
yeah. So if you have a client, let's say, for example, that exact scenario is that you have a dog who has separation related distress. Um, I say separation related distress because I don't always label it separation anxiety because
I don't either.
it
Yeah,
could be
confinement. Yeah.
confinement, it could be frustration, boredom,
Generalized
all of that,
anxiety. Yeah.
noise phobia, all of that.
Yes, absolutely.
So but if it's a scenario that it seems to only happen when either both pet parents are gone or one pet parent is gone, then it's separation related. Um, then we can go on the whole abandonment anxiety as well. But anyways, so let's say, for example, we have a pet parent who has a dog like that, and it affects the human's quality of life in the sense that they can't leave their house, they feel trapped, which many owners do. Um, and it can get quite expensive to be like, oh, I have to take my dog to doggy daycare because they can't be left
Yes.
at home, and so
Yes.
on and so forth. I tell my pet parents that in that scenario, and you have a dog who has separation related issues, but you also need to live your life, and that we will be using 2 different types of medications. One is like we said, the one that builds up in the system, like an SSRI.
Right.
And then the problem is that if I'm saying the gold standard of a separation related case is to not leave the pet alone for them to keep practicing that behavior, then I need an as needed medication so that the pet parent can still go to work, leave their pet at home. And I will use sedatives. Then there are going to be the days that they practice. So
Practice?
there's practice going. So that's the
Ah,
training
okay.
days.
Right.
And let's say we're actually training it once a week. Because if we say realistically, most people are working Monday to Friday, 9 to 5, and they have their own lives. And so if we want them to dedicate time to actually train their dog to be okay with leaving, then I'll use a different drug class, one that you mentioned earlier, which is the alpha 2 agonist. Because even though that group of classes can cause sedation, I find that they can still learn
Okay.
with that on board. Because if we use something like a benzodiazepine, it causes amnesia in people. And so if it causes amnesia in people, my expectation is that it would also cause amnesia in a dog. But if I need to use that on a daily basis, just so like Monday to Friday they can go to work,
Right.
then we would. So it's sort of dividing up their week of like, this is real life. You're Monday to Friday, 5 days a week, you have to go to work. So what medication can we give that dog so that they can be okay with you
Right.
leaving?
So I see some, Meg just asked, so would that be like, for example, fluoxetine every day and Traz on training days? Or Traz on the days that the person has to leave? Right.
Yeah,
Not training days. Right.
yeah. So
To
because,
reduce the practice of the anxiety. Right.
yeah. Now you could use trazodone on training days, but we wouldn't know what the effect is for that pet. Um, the trazodone binds histamine first, and
I heard
so
you say that in a post the other day that I thought was so interesting. You said
mhm,
it's like Benadryl.
yes, exactly. So trazodone in humans they use for insomnia,
Mhm.
and uh, if I have a pet that comes to me already on trazodone and the client reports that it does best on this, then I kind of layer on top of that and then I try to wean the trazodone, being they're like, if they are on that for daily medication. But if it works well for their separation, then we want to keep that on there and assess their ability to learn with maybe a lower dose or something like
Right.
that.
And I think, I mean, from my experience, and obviously I'm not a doctor, I just play one on TV. I had to. I I tend to work with dogs with more aberrant behaviors, aggression, and gnarly stuff. And so
Yeah,
Traz is not something I want that dog on because of all of the potential impact it may have on behaviors like bite inhibition. And I see dogs become almost paranoid on it and they blow through it and then their behaviors increase. Like if it's white coat syndrome, they're afraid to go to the vet and so on.
yeah,
I want to ask you, I'm not sure exactly how to phrase this, but I, in the last few years, have become increasingly aware of the vast number of pets with behavior issues are struggling with so many different things that to me it's almost feeling like this pervasive panic attack that just manifests in different ways, right? Like separation anxiety is a panic response to someone leaving them. Confinement anxiety is a panic response to being confined. Fear, fight or flight, all of those things are some kind of like what. And I have been focusing much more on the nervous system to try to stabilize that CNS response. I, I suppose my question to you is when the behaviors are really tough, but appear to be layered. At what point do we try to decode or determine how we're layering, adding medication, knowing which one is doing what, where our baseline has gone? Do you know what I'm asking? I don't know if I'm
Hmm.
very clear.
Yeah.
It feels like a very, like this mashed up picture that constantly needs reevaluating.
Yes,
And
for
how
sure.
do we know, like the dog that was just in my home, I knew that something's wrong with her brain. I could tell the behaviors were not normally presented behaviors. It was snaking and ground crawling and lizard. I mean, clearly something very wrong with the brain, and I've seen it before, so it was something I recognized. But at what point do we know whether all of our efforts are actually tracking us in the right direction when all of this, like you're just explaining an SSRI is so complicated? What happens with all of the other things that we're trying to deal with, and how do pet parents figure out what to ask their dog? I see there's like 100 new messages here, so we will get to them, I promise. We'll do our
And
best anyway.
what question should a pet parent ask their veterinarian, as in their primary care veterinarian?
Yeah.
So the primary care veterinarian will look at their own clinical experience. The ones that are savvy in behavior meds have tried medications in the past. The concern becomes the lack of follow-up. It's like, here's your medication, go
Yes.
see a trainer.
Yes.
And then if there's no follow-up on there, and let's say, for example, the client gets directed to an inappropriate trainer,
Yes.
then there's like some trainers who will take dogs off medications and just like take them off suddenly. And so it's I would say a challenge for primary care veterinarians. They would choose their first line of like, this is what I'm comfortable with, this is what I'm going to use. And let's if we mirror that with your family physician, and we say in human psychiatry, your family physician is going to be comfortable with a specific SSRI. They're going to say, here's your SSRI, we'll titrate up, and this is the dose. But if it's a complicated um, disease process, referral to a psychiatrist ends up being what the primary care would do.
Right. Right.
And we, the
Yes.
veterinary behavioral world, even though we call it veterinary behavior, we are the psychologist and psychiatrist amalgamated in one, because we have to learn all about learning theory, how to modify the behavior, basically the behavioral therapy, and all of the psychiatric medications. So we are essentially veterinary psychiatrists. And so if a primary care veterinarian doesn't know when they're in over their head or when to refer, then the pet parent can get lost in the mix. And so a pet parent, and many pet parents they're very good at advocating for their pets. And so if you have a pet parent that is struggling and their primary care, let's say, chose Traz as a daily medication, then the pet parent can ask for a referral. If they are savvy, they go on the website for the American College of Veterinary Behaviorists and look for one. Some of them will do self-referrals. Some of them need a referral from the primary care. And some of them will do telemedicine across state borders.
Yes, I know that's true. I think the problem that many of my clients have been running into, and I myself, um, we have the dog trainers, we have the vets, we have the veterinary behaviorists, we have the behavior consultants. Not everyone with a title is good at what they do. And so a lot of the pet parents who are trying to do the right thing and seek out a veterinary behaviorist are either put on very long waiting lists and charged absolutely exorbitant amounts of money, which is, I'm not judging what anybody deserves to make. I'm just saying it's out of the realm of doable for a lot of people. And then it's copious note taking and then a bunch of prescriptions. But as you say, that follow up is kind of like titrating up or down or adding this or taking that away. But I don't get the feeling that the attention to detail in the very subtle shifts in behavior, like there's not a lot of creative problem solving in that process. And so I'm seeing people almost have more success sourcing out fear-free vets who seem
Yeah.
to have a more broad and intelligent understanding of medication as it relates to behavior, but still fall into a more time-wise, a timeline that's more doable for a pet parent and
Yes.
set up in a way that a dog can come in without having to sit in a waiting room, all of those other things, right?
Yeah.
Um, And now we have a number of very different specific medications that are really designed to either be for noise phobia or for impulsive responses and cocktails are sort of layered in. What how do you decide, let's say can I give you a hypothetical?
Yeah.
Okay. Um How do you decide for a dog who, let's say, has a trauma background or anxiety or shelter stray kind of situation? We don't know where they came from. We don't know what the mom went through. We don't know how long they were with mom, all of those things. Dog is presenting with fear-based aggression or just unwelcoming behavior that is difficult to manage, and their world is getting smaller and smaller, or reactivity or whatever. How do you decide between Prozac and Zoloft or Reconcile or adding in gabapentin or adding in clonidine or adding in clonicalm or adding, how do you determine what, because so when I was talking to Dr. Forbes about using this or that, she said in this case I don't remember exactly what she said because it was several weeks ago, but something like I would probably not be inclined to point in the direction of Zoloft for certain behaviors because it might create more edginess or kind of angst in the dog. So these are things that I wouldn't know. I wouldn't even know to ask. But how do we know, oh, that's just an initial loading period, or, oh, we don't know if that's just the body acclimating? When you're evaluating what you want to do, what's your general thought process and how do you come to those decisions? Because I feel like for these people, maybe it would help
Yeah.
to hear how you
Yeah.
think about it.
Yeah, for sure. So let's say we're sitting down, hypothetically speaking, I'm in an initial consult with a behavior client. These behavior clients are referred to me. They're either on medications already or their primary care was not comfortable with medications and they come to me as a clean slate. So there's two different categories. Let's say clean slate, never started down any medications. What is the medical history of that pet? Do they have any gastrointestinal issues? What is the concern? Do they, say, for example, get stress-induced colitis? Do they have a good appetite? Are they in any pain? And I'm not looking at the medical record just to pull out like all of that stuff, but I essentially spend probably an hour to 2 hours prior to the consult, going through the medical records and pulling out every single thing that is important to me that could affect behavior. And it's not because I'm trying to scrutinize the veterinarian, but oh, they came in for limping, but we didn't have any x-rays done.
Okay.
I have some of them that if they're coming in to see me and they sit weird, I ask the client, can they sit in a square sit? Can you ask them to sit in a square sit? And if they can't ask them to sit in a square sit, there's something wrong.
Right.
And
Yes. Yes.
so,
Yes. We
so
don't,
then,
but most people are not asking those questions. You see, this is why I wanted you here, because the way you think and the way you observe animals is not what most people are doing.
yes, exactly. And let's say, for example, I'm doing a virtual call because I do get some that I'm meeting with the pet parent just like this, and I don't see the pet. I send them a handout and I say, get me some videos.
Mhm.
I want to see them going up and down the stairs inside their home because the dogs can be inhibited in the vet clinic. And so there's some that will actually just lie down. I'm like, well, I didn't get to see them move around at all because
You think that like
they're
the
just,
adrenaline is overriding any discomfort?
and that happens as well.
Yeah.
And um, a few years ago, there's a group of veterinary behaviorists that basically surveyed themselves. How many of your patients come with a painful condition that's not being handled? And so it's up to 80%. I would say probably 50% of my cases have some sort of pain component, whether that
Yes. Mine too, at least.
musculoskeletal,
Right.
dermatological,
Mm-hmm.
gastrointestinal. Those would
Mm-hmm.
be like my like top three. Could there be some neuro? Maybe, but I have very few that are like neurologically abnormal. But a lot of musculoskeletal, a lot of gastro, and a lot of derm. Um, and I say to the pet parents, I'm like, if we can't get control of your dog's itchiness, I'm not going to be able to help them as best I could with their behavior.
Right. Same. Yeah, absolutely. It's too uncomfortable to be on good behavior. Right.
Yeah. And so then that affects their ability to sleep.
Yep.
Pain affects their ability to sleep. And I asked them, how many hours does your dog sleep in a 24-hour period? Did you know they need more sleep than humans? They should be, 14 to 16 hours in that 24-hour period. And the number of people that go, oh my gosh, no, they're definitely not getting that. Like they sleep when I lie down, but they're not sleeping during the day. And
And
like,
they
well, we
sleep
need,
with one eye open. Right. Yeah.
or they're resting, they're lying down, but they have to be touching their owner in order
Yes.
to sleep. If
It's
the
not
owner gets
restorative
up,
in any way. Yes.
exactly.
Yeah.
Yeah. And I asked them, does your dog dream? Do you see them dreaming? Because then I know for sure they're going through the cycles
REM sleep
of sleep.
cycle. Yeah.
Yeah. So that all it comes
14 to
before I,
16 hours, Jesse. Sorry, she didn't hear what you said.
yeah, yeah. So that's kind of the first step is going through the medical history and determining if I am looking at this dog and only having to treat their behavior, or if I'm looking at this dog and I need to treat all of their medical problems in addition to their behavior.
Daunting.
And so if I look at them and I'm like, oh my gosh, this dog is painful, and the owner doesn't think that they are.
Mm.
I'm like, but you just told me if they go on a long hike, they limp afterwards. Then I'm like, I need to address the pain. And so in my sense, I can reach for medications that cover for anxiety and pain together because I need to treat the pain or I'm not going to be successful in treating the
Including the
behavior.
behavior. Yes. Understood.
And so there are some. So we talked about the SSRIs. Then I might be reaching for an SNRI. or I might layer on one of the gabapentinoids. And so in that way, at least I'm giving the dog some relief. There's a few that all I do is treat their pain and their behaviors get better.
Same. I don't prescribe, but I'm
Yeah.
telling them what to ask for, guiding them towards that. And it's interesting because I have clients all over the globe, and by culture, things are, I'm sure you do too, things are very different. So, you know, like in the UK, people are not at, or many of the people I work with, not, they're like, I'm not giving my dog meds, right? Or trainers that I'm working with who are dealing with clients, certain cultures, Spain, they're not, what are you talking about? Dog doesn't need medication. So
Hmm.
depending on where they are, it's even harder for pet professionals to be able to get to the root of the problem because we're not, the pet parent is not acknowledging that there is a problem, right?
Right. Yeah.
So back to my question about what would be, how would you determine whether you want to, which SSRI you would be prescribing? So how do you decide if it's a Zoloft or a fluoxetine or a
If it's
trazodone or a gabapentin or something, you know, which of which category? What makes you determine one over the other? Is it the gastro aspect?
so let's say we have a completely normal dog in the sense of doesn't have any on current medical issues.
Okay.
We start with veterinary labeled first because legally, as a veterinarian, we should be starting with veterinary labeled first because we have a decision cascade that says start with on labeled medications. So if it's a dog, we're starting with Reconcile or Clomicalm or Celio or Boncat for cats. So you're starting with on label first. It doesn't mean that that's what I do, but legally, that's what we should be doing.
Can you explain what veterinary label means?
So there is a drug identification number on our medications. It's different than your supplements. Anything with a drug identification number, a DIN, requires a prescription. And we have a decision cascade, and a decision cascade says this medication has been tested in dogs and is actually labeled for dogs. It has the label, it says for dogs only or for veterinary use only, something like that. And then if we determine that either the pet won't take that formulation or there's no labeled formulation for that species,
Okay.
let's say, for example, cats, there's no Reconcile for cats. So I could use dog label medication for a cat, but it's considered extra label. Some people call it off label, but extra label. It's been studied in cats. It's just not labeled for cats.
Understood. Okay.
But then, me as a veterinarian, I take the responsibility for any adverse effects that that pet experiences when taking a medication that's not labeled for that species.
And is that something that concerns you to do that? Is that something you prefer not to do?
Sorry, like prefer not to.
Meaning if it's an off-label medication because you're saying you take the responsibility because it
Mm.
doesn't have, is that something that you prefer to avoid?
I always preface that with the client. I say, legally, I should reach for veterinary products first. But let's say, for example, I'm like, your dog doesn't eat very well. The most common side effect of Reconcile is they're going to have a
Lose their
reduction in
appetite.
appetite.
Yes.
And so in that case, maybe I am reaching for cert, you know, Zoloft.
Okay.
And so The other flip side of it is the size of the patient. So in human medicine, they don't dose based on milligram per kilogram, they dose on human. And so the average human starts on this dose, but humans can be in a quite wide range in body weight as well. Whereas we are dosing based on body weight. And so if I have a chihuahua and it's yay big, I can't dose appropriately with Zoloft
Okay.
because the size of the capsule would be an overdose as the starting dose.
Understood.
And so then if we have veterinary and then we have veterinary off-label for that like non-species, then it's human labeled, then it's compounded. Compounded is way down at the bottom, but we compound a lot for our exotic species, so parrots, um, guinea pigs, rabbits, and cats, because sometimes you can't pill a cat.
Right.
So, depending on the size of the pet, I might say, my first choice would have been Zoloft, but I can't use Zoloft because it comes in a 25 milligram capsule. I'm going to reach for something else that I know comes in a smaller tablet.
So when we're looking at dosing, I often see dogs being dosed per weight, as per their weight.
Yeah.
And I personally don't care for that approach, primarily because every dog's response to medication is different. I've had 100-pound dogs who could only tolerate 20 milligrams of fluoxetine, and I've had 50-pound dogs who needed 60 milligrams of fluoxetine. It's very much the way that it interfaces with that animal or interacts with that animal's brain. Now, I also want to be careful that I'm not putting an animal or a pet parent in a situation where they're getting too much and the vet doesn't know to look for those nuances. And now we've got a dog who's completely flattened out emotionally or having some kind of adverse reaction. And I see people prescribing cocktails right away, as opposed to slowly layering one in at a time and seeing if we really need more or if the dosing is appropriate. But most pet parents don't know to ask those questions or frame those conversations. How do they? I guide them, specifically say these words,
Hmm.
ask for it to be divided so you can do morning and night, but really what you're doing is reducing it by half to make sure it's not too much.
Hmm.
But that's why I talk about it all the time and want to have conversations with people like you, because there's not enough discussion as to the detail per animal and what pet parents should know to look for.
Yeah.
I find that
We
very frustrating.
we dose on body weight kilograms because that's what the research says. The concern becomes is that we should actually be dosing on surface area to volume ratio, but the math is harder.
What does that mean? Surface area, the surface area of the body?
Surface area to volume ratio. That's what we should be dosing on. But because the math is harder, we don't. We just use milligrams per kilogram because the math is easier. But we should be dosing based on the surface area to volume ratio of the pet. That little chihuahua that I was talking about, that has a higher surface area to volume ratio. They have a
What's
small
the volume
volume,
part represent?
the volume of the body
And the surface area of the body?
is the skin.
That's fascinating. I've never heard that before.
So your large breed dog, your 100-pound dog, has a smaller surface area to volume ratio.
Wow.
And so your chihuahua is going to need a higher dose
Isn't
than
that cool? Yeah.
your Great Dane.
That's fascinating.
But we don't, because the math is hard. Like,
It's
I'm
so we
like,
don't do
let me
that.
figure it out what the body
Right.
surface, like, no, it's just. So they should start low. The problem is that you look at the pet and you say, how intense is the reaction? Where are my goals? How much assistance do they need from a pharmacological sense? And tolerance of the medication. So sometimes I will start under the recommended dosing range. So if your dosing range is 1 to 2 milligrams per kilogram once daily, maybe I'm starting as, but it also depends on the size of the tablets.
So someone is asking, Elliot is asking, would that be different in lean dogs versus round dogs? Thinking like Whopper shape versus Bulldog shape.
Yeah, so when you punch it in, you get like different calculations of trying to determine what their surface area to volume ratio is.
That's so interesting. I've never heard that before.
Look at that
But you
bulldog with
don't
all
do
her
that
loose
in.
skin. Um, so the only time that I'm like, okay, I'll sit down and calculate this is with Cilio because it's actually that's what it's labeled as is 125 milligrams per meter square. So I need to figure out what is the meter square of this pet.
So, okay. Now, when we start getting into the derm aspect of things, okay, let's shift
Mhm.
away from the SSRIs because I think we all know that an uncomfortable dog, be it from pain or allergies or gastro, we're not going to get the right landscape for stability if there's discomfort. There are medications that terrify me. Apoquel is one of them, or as some people call it, Apoquel, but I refer to it as Apoquel. I've seen terrible responses behaviorally in terms of increased aggression on that medication and my fear of what it actually does inside as opposed to the big pharma making things look good on the outside would prevent me from ever using that again. I know that it's one of the first lines of defense that will recommend. So we have this incredible bounce back loop where dog is uncomfortable, pet parent brings pet to vet gives them the big pharma answer. Things look increasingly better very quickly on the outside, but it's short lasting and it's not getting to the root of the problem. So we haven't really addressed the gut microbiome or the overall health of the dog or environmental allergies, which we can't change with diet. So we need to really be looking at increasing the wellness of the immune system, correct?
Um, I don't think that we know fully how to modify the microbiome. There's a ton of like research in it,
I've seen.
but we we don't know.
No, but we know that feeding in a certain way could make it less functional.
Correct. Yeah.
So,
And
well,
then a dog that has environmental allergies and no food allergies, they can have cross contamination. Let's say they're allergic to grass and they break out in their skin because of a grass type of allergy. There might be some cross contamination in their food.
so as we work through dealing with allergies, because I've gone through that rodeo several times with success, I tend to pare down everything, right? And less medication, more of a holistic approach. But I know
Mhm.
that there are dogs who are really struggling, eating themselves alive, like self-mutilating over discomfort.
Yeah.
what do we do for those animals without risking them becoming really sick as a result of the medications we might be putting in their bodies?
Right. I use Apical a lot
Okay.
because I know that it works. And there are some that can have an increase in aggression with Apical.
Or cancer.
It doesn't cause cancer.
It blocks the body from detecting cancer cells,
It is an immunosuppressant.
which means they can multiply rapidly.
It can,
Yes,
yes. But a
that scares me.
genetically predisposed dog who's going to develop cancer anyways is not causing the cancer. And I think
No.
that's one thing that we need to get away from, having that like cause effect. It doesn't cause cancer. But same goes for our pets who have um, mites under their skin.
Mm.
You got an itchy dog because of mites and you give them Apoquel, you're not treating the underlying cause. And so you need to treat the mites to treat the itchiness. And so part of it comes down to ensuring that we have the appropriate diagnosis.
Diagnosis. But and this is where all of this stuff becomes so incredibly complicated, I think, is how do we find people to go to who are thoroughly diagnosing these
Yeah,
conditions so that we don't end up putting dogs who might be predisposed in a situation where they could actually become more sick because they haven't been diagnosed properly.
correct.
And I understand that Apoquel does not cause cancer, but I still think it's a really risky medication for a lot of dogs, and it doesn't solve the problem, it just relieves the problem in the moment.
Yeah. And part of it is that for environmental allergies, even the pets that go through and get tested and they get put on immunotherapy, they don't necessarily
Get better.
get better.
So how do you address that? Cytopoint is a really good question. I know people, do you think that Cytopoint is significantly better than Benadryl?
Yes.
And what about one of my clients just told me about something I had not heard of before. That's a different injection that is supposed to take a year to work. Nextune or next something, I can't remember. Have you heard of that? That's
That
not.
one, that one does not ring a bell.
No, I'd never heard of it either. But Cytopoint, over if you're keeping it continuously in the dog's body rather than letting too much time go by, that can become effective as a longer term on the road to wellness product, correct?
For the Cytopoint,
Yes.
it depends again on the diagnosis. Because looking at like dermatologists and
Next
how
Mune.
they,
Yes.
sorry,
Sorry. Next Mune is that.
Nextmune.
Yeah.
I don't know. I don't know what Nextmune is.
No, I didn't either.
Um, Canada's behind the US as well. The other thing too is that North America is behind Europe. Things will go out in Europe first, and then they come to North America.
I'm not entirely sure. Maybe you know. Hi, Dr. Forbes. You two know each other?
Yeah, we follow each other.
Do you want to come up and talk with us too? I'm happy to talk to both of you. It's so I don't know how to invite you. Ask me. Is that okay with you, Dr. Serena?
Yeah, for
Yeah,
sure.
we can circle back to the Cytopoint conversation. You have to, I'm not good at inviting. I don't know how to do it. So you like Cytopoint as an answer to.
So what I was going to say is that if you I work with a dermatologist. I had because I work in a hybrid practice. Basically, the hospital has both general practitioners and specialists. Dr. Forbes,
Yay!
I
you
don't
figured it out.
I don't want to crash the party, but when I see two awesome people, I can't resist.
You look
I
like
don't want to interrupt you, Dr. Serena, but Dr. Forbes, I don't know if you know this or not, but you and I are working together on a client.
I know. I saw her
Okay, so
yesterday,
yes, I
and
knew she was seeing you on a Friday, and you and I need to talk about that.
oh
This,
my gosh,
yes,
yes.
this for anyone who has been following. I had shared a post about one of the most horrific stories I have ever heard, and that is a client of mine and a client of Dr. Forbes. So yes, so you and I maybe tomorrow we'll talk about.
I think that sounds great. Very sorry to crash. I will just be here to be a part of the awesomeness that you guys already
We're
started.
talking about allergies and cytopoints, so I'd love to hear from both of you.
Yeah, I agree with Dr. Serena. It depends on the diagnosis, but I actually really love Cytopoint. For the patients that it works for, it's fantastic, right? It's an absolute saving grace. And I know Dr. Serena and I overlap with our interests in behavior, but she's actually a resident in training. Um, I think that we very much underserve our allergy kiddos and I think that contributes to behavior because it's just so miserable to be that itchy.
Without question. Without question. And you
yeah.
two are such rock stars.
No, right back
I
at you,
want you
Hillary.
to
Right
take
back at
over
you.
the world.
um, so yeah, I work with a dermatologist, and for ears, she says you won't get as much effect with Cytopoint.
By the point.
But they say the same
Interesting.
thing about Apoquel. Actually, when you talk to certain dermatologists, and I don't know if you've had this experience, but they'll say the same thing about Apoquel. And apparently, Zenrelia has a better profile for ear infections. I'd love to see what you think about that.
I haven't started it. It's only recently been released in Canada.
Okay.
Is that because it's not systemic and the ear canal is not going to get the medication as easily as the body?
I don't know the difference.
Possible.
I don't know
Yeah.
the difference yet. I have not personally started using Zenrelia because it has a black box warning that I was like, ooh, let me just learn about it.
Don't be the first to do it.
Exactly. But to be fair, I think Apoquel would have the same black box warning if it were passed today and not 10 years ago. So just like,
Mm,
We were
just
just talking about Apoquel. Dr. Serena likes Apoquel. I think we all know how I feel about it. You know, I know you like it too. I'm like, no, that's the devil.
mhm,
But wait, I
mhm.
want to go back to something you said, Dr. Serena, about the Canada being behind North America being behind Europe. If I'm not mistaken, because I know with Jude, I was doing quite a bit of research probably a year ago, although these months are starting to blend together, as are the dogs. But I remember there was a big blast about Librela last year. And there was also a lot of backlash, especially for any dogs that had seizure activity. But there was a big pharma push to get Librela out to all the vet offices because I had clients who work as vet techs and they're like, oh, they were here and we've got all of it and it's doing so much and on and on. And then as I started to research deeper, it appeared that the version of Librela, and I could have this wrong because often I am, but the European version of what was being given as Librela was not the same as what was being given in the US because of our FDA regulations or how I don't know what the details of all of that were. Because they were having great success in Europe with Librela and then this huge backlash in the States. Do you guys have any idea what I'm talking about? Or
no.
okay.
Do you know, Dr. Serena? I'm not familiar with that.
I don't I don't know that it's a different product. That part I wouldn't know.
Okay.
I don't know. I do think that
Just a
it
very different response to dogs getting sick on that product here and not in Europe.
social media is such a powerful driver of the anecdotal story
I know.
that
I
it's
know.
really hard to compare apples to apples. And I don't say that in a way to minimize people's experiences because there are absolutely people who have had their pets they gave their pets Librela and their pets absolutely declined afterwards. So I don't want to minimize that. It's really hard to distinguish between all the anecdotal stories, because the other piece of this is a lot of the patients receiving Librela are like 16-year-old patients that have 20 comorbidities, and then we give them something that, like, was it the Librela or was it the 20 comorbidities? I am very, very picky about screening for Librela. I do use it, but I am extremely picky about screening for it. I don't know.
But that is where the difference and problem lies.
Yeah.
So before you joined, Dr. Serena and I were talking about, she was explaining what her consultation entails and what she's looking like for those magical little nuggets in the history that could be, well, what has this been explored, or how do you, that does not happen for a typical pet parent when they go for any kind of medical help. That's why you two are worth the pedestals that you're on.
I appreciate that. It's a very humbling situation to be, grouped together with you, Dr. Serena, but I appreciate that. I think it's also, thank you very much.
I'll have what she's having.
Right? I got some bibimbap from my son who doesn't want it.
Good
I'll
son.
take it. I know, right? He's sharing his bibimbap with me. Like, that's love. Thanks, Levi. So what do you use it, Dr. Serena? Does your practice use it? Do you like it?
For which? Librela?
Librela.
Yeah, we do. But it's the same thing, screening and ensuring that we're using it appropriately. And a lot of it comes down to ensuring appropriate client consent, is understanding what the medication does and why we're using it. So I don't give it to anyone. It's never my first line for osteoarthritis.
Yep.
I think someone said, what about IBDD? It's not my first line for IBDD.
Oh, I won't use it in a dog with IBDD.
And to the point where it has, in theory, accelerated some erosive arthritis.
Okay, wait. I'm interrupting you. You'll forgive me, right? I have to, because Dr. Serena had a post about, and Ezra, I don't know if you're here, I sent it to you this afternoon. You have both spoken, Dr. Forbes and I have spoken about this privately. Do you know what I'm going to say? No, you don't.
Go ahead. I think so.
What am I?
No, go ahead. No. I don't want to interrupt. Please.
You know me so well.
I'm going to take you down a different path.
Now I could do anything, just to mix you up. I have heard Dr. Serena talk about this in a post this morning, and Dr. Forbes and I have talked about this privately when I was dealing with some significant pain for Jude, ready to drive to Ann Arbor to deal. You've both spoken about ketamine.
Oh, yeah, no, I did not know where you were going. Nope, okay. Yep.
You were wrong. I surprised. I'm the oldest. I get to be able to just psych you out a little bit. I believe you call it ketamine infusions.
Yes.
Can you both speak to everyone about ketamine? Because it sounds like it's a newer protocol that is something I know you have a lot of confidence in. I would love to hear your thoughts, because we're dealing with so many dogs that have pain. And I don't know that there's a lot of knowledge on the pet parent side of things as to what options are they may be asking for.
Please go ahead.
Want me to start?
This is your eye crash.
Well,
so you start.
While you're eating.
Thanks.
Notice she didn't give anybody else anything to eat, but that's okay.
Where's my plate?
Mine too.
Levi.
Thank you, Casey. I'm glad you're enjoying it. They're amazing. I know, I love them.
Oh, thanks.
So ketamine. I'm probably not supposed to say that
Let's
word.
just call it K. Well, that's probably not
Oh,
good either. Keta. We'll
yeah.
call it
Yeah.
Keta.
Uh, so, continuous rate infusion, or CRI. It's used in the specialty world under the rehabilitation and pain specialists. That being said, as a general practitioners can, borrow that information if we have the ability to do that in our facility. And I have for some of my patients with chronic pain, because a multimodal approach to pain is the best way, because if we can lower the dose of some of the other medication, we lower the side effect of those other medications. So if I have a dog who has been on a nonsteroidal anti-inflammatory long term and they're not doing as well on it, can I wean that down to a lower dose and add on an adjunctive medication? It can be given by infusion, which is an intravenous infusion. They have to
Which is
be,
what I think Dr. Forbes had talked to me about. Yeah, it's fascinating.
Mhm.
It's like
they
if
have
you
to
could
be,
reboot the neural pathways or the nerve pain points. It's really interesting.
yeah. So being an NMDA antagonist, it will block the NMDA receptors. And that comes basically because pain itself is perception. And each of us will feel a
Right.
painful stimulus differently.
Definitely. Yeah.
In
And then
some
once
of
you get
our,
into chronic pain, then it's got its own vicious, like self-perpetuating cycle that's separate from the acute pain, right? So then you're chasing pain, which is its own separate issue altogether.
and chronic pain being maladaptive. So if we
Right.
can change how the brain perceives pain, then the animal can be in less pain because they don't perceive it as
Right.
much.
Right.
So that's how it works.
So with the ketamine infusion, with sorry, I know. So do the effects last longer with sequential infusions? So right, so that's where I was going to go with this next. When you're doing that, Dr. Forbes, when you and I talked about it, it was going to be kind of like 2 continuous days of infusions to kind of reboot the whole circuitry, right? Where the dog would be knocked out completely and just on this infusion. And then you said you have seen dogs wake up from that and like move in ways they were not able to move before. So do you have any sense a couple of questions. So like, is that something that you wouldn't trust a lot of people to do?
It depends. You have to have proper monitoring. And they're not completely knocked out in the sense that they're like anesthetized, but ketamine is sedating. So you have to have someone monitoring them. It's not an infusion. Well, no infusion is something that you can just walk away from, but you do have to have someone that is properly monitoring. The other thing though is that in my experience, ketamine is something that can be injected on a monthly basis
Okay.
to maintain pain control. But also for those kiddos, because of doing high FAS patients, I will also use amantadine, which is in the same class of drugs, after an infusion, so that we don't have so much
Just to
stress if it's
maintain the effect of
right,
it.
right. So
Interesting.
that's what I've used, and every patient is different. Their tolerance for the medications is different. Their response to the medications is different. I had an I have an IVDD patient who is extremely high FAS, very high bite risk, huge dog, 90-pound dog. And he has horrific lumbosacral disease and he was in excruciating pain. So we sedated him, placed an IV catheter, did a ketamine CRI for 48 hours. I did acupuncture and he bolted out of the clinic into the car. And then, so I sent him home and he's on pregabalin, amantadine, and a lower dose of carprofen, and that, or not, sorry, not carprofen, pred, by the neurologist. They wanted him to be on a steroid instead of an NSAID, and he is doing fantastic on that. So that little reboot was what he needed. That might not work for a different patient, right? That's what he needed, but it depends on the disease and the patient. And
But I think it's so important for people to know that there are other things that their vets might not be aware of,
Yeah.
and what to ask for. So like if we have a pet parent, so Ezra with Zyla, you know, I think you and I talked about that dog, right? This dog is 3 years old and cries every day for hours, and they're desperately trying to find pain solutions. But I'll bet you that they've never thought about that as a concept because it hasn't been recommended to them.
potentially.
Yeah.
Serena, do you use amantadine?
I have a few patients on it. But yeah, I recommend that if we're going to do um, the CRIs, to do it for a minimum of 4 hours. And that means that the pet has to sit in a hospital for 4 hours. So they have to be amenable to that.
But they're sort of sedated, so it's not as difficult, right?
Not always.
Okay.
I mean, we sedate them if it's pain. If it's a difficult patient, we will sedate them in addition to the ketamine.
Right. Okay. I love the fact that there are different approaches that we can offer people. Now we just have to make that knowledge more widespread so that people can find the appropriate doctor to be able to offer them more than just these generic answers to complicated problems.
And can I just throw out there for the poor cats in the world who have forever and always never gotten any pain control or options for arthritis or discussion about the arthritis, or no one even notices that their cat has arthritis? Like, you know, like almost 70% of cats by the time they're 6 years old have arthritis. Like there's a lot of cats experiencing a lot of arthritis. There are options for them as well. And Solensia is a beautiful injection for them that I have seen amazing results with. So Solensia is nice, and gabapentin, pregabalin, those are nice things too. So there are options, and joint supplements. So
you know, when Jude was dealing with his spinal stenosis, he got to a point where he could barely stand up and he couldn't walk down the driveway. And pain was, before his cancer diagnosis, pain was such a prevalent part of his life. And I pushed to get a steroid injection, epidural, right? So not an epidural, a steroid injection. Is that what am I taught?
You can give it by epidural.
By epidural. So, but they had to put him under anesthesia. But when that dog woke up, he was running like a puppy 2 days later. And I've never seen so much joy. And this is an animal that lived most of his life in a box.
No.
And because it was so effective, we did it again. And unfortunately, the side effect of the anesthesia seemed to bring on cognitive canine dysfunction. And there was some decline there. But for the time that he had, he was happy, not in pain. But I had to ask for that. It was never offered to me.
Great.
And the only reason I knew about it was because I'd done it several times myself.
Yeah.
And cured me of pain for a very long time.
And it would be usually under the direction of a neurologist.
Yeah.
And
This
I think
is
your
an orthopedic surgeon.
Yeah.
So it's not like general practitioners couldn't, but
They shouldn't.
if they are not comfortable with it and they don't do it frequently, then they're going to want to refer because they don't want to mess it up.
No, for sure.
You inject it in the wrong spot.
And you're got a problem. Yeah, for sure. Do either of you subscribe to things like red light therapy? I know acupuncture for sure. And there's also laser therapy and what is it, PEMF. So can you talk through some of those options for people with dogs who have pain?
I personally,
I
we have
I was just
shockwave.
gonna say, I'm like, you can do the whole like holistic discussion and all of that. I think that it would be helpful, but it's never going to match our pharmaceuticals.
Okay.
So that's interesting because I have a dog. So I have not made a video about him yet, and I really need to. I have a patient, Gibson, who is a double digit pity. He is a behavior friend who, hates coming to the vet, historically had to be sedated for everything, very, very fearful of the vet. And he also, as a puppy, had an obstruction and surgery and now suffers from what we assume to be probably post surgical adhesions, meaning like,
Ulcers tissue. Yeah.
yeah, so things don't go through his GI tract normally, and his GI tract has never been the same. This was all done historic to us, so I don't really know personally, but he literally cannot take any oral medication. We have tried everything. There is nothing that dog can take orally. Even Serenia makes him throw up. Like anything that goes, right? I mean, it's bad when Serenia makes him vomit. So he cannot take anything orally, and he experiences profound arthritis pain. And so his mom came to me like, what do we have left? Right? Because he is quote unquote difficult to deal with. They came to us with this, like, he is fearful of the vet. He's not an easy patient to just like do X, Y, he can't just like come in every week for laser because he's terrified. And I suggested acupuncture. I said, let's give it a go. They had a really good relationship with him. He trusted them. I said, you take the front end, I'll take the back end. Let's just start there. They told me after our first, I do pain consults with my clients. Like I set aside time and do full consult and just talk about pain management if I have a patient who's in pain. And they told me that after that consult, they went out with a group of their friends and literally spent an hour and a half laughing at me because I had suggested acupuncture for their dog. And everybody in their circle of friends who knew Gibson, they were all like, oh my God, that's the funniest thing. Like, you have to tell us how the appointment goes. That is going to be such a, like, oh my God, this lady's crazy. Gibson came in and I put 3 needles in. I started. He melted onto my lap. And he has come in every 2 weeks for the past year and is living his best life on only acupuncture. It's the only thing he can tolerate.
Crazy.
It is phenomenal. Now, not all patients are like that, right?
It's never going to do anything for bone on bone pain.
No,
right? It's never. That's not
right. But there is a world, as Dr. Serena said, it's multimodal. So he's an exceptional case because I can't give him multimodal because this is all he'll tolerate. We are doing a CC for him at home, and he has gotten to the point where he will tolerate that. He's not afraid of it. He's afraid of everything. So they've done a good job of introducing that. So, my approach is there's laser therapy, which is light therapy. There's shockwave, which is sound therapy. And then there's acupuncture and then the PMF. I like the PMF because my high FAS patients can do it at home.
right.
Laser, sound, and PMF all have some contraindications with cancer. So it is important to know if there are high replicating cells because all of those modalities will
Activate that.
Yeah, they'll bring mediators to those areas that will activate those cells. And so it's not a no-go. Like if I have a 16-year-old patient who's in a ton of pain, we have the conversation. Again, like Dr. Serena said, we have the conversation. Like, here are the pros and cons. I might accelerate cancer. Like I just had an osteosarcoma patient who we had the conversation of like, do you want to do some laser in the very short term? It was 6 months out after diagnosis. Again, that dog was managed with oral medications and acupuncture for 6 months, had a great life. And at the very end, we had the conversation. Do you want a few more weeks? Do you want to try laser? It might speed things up, but for a very short period of time, we might get some relief. We opted not to, but those are the conversations that we have to have. But I love all of those modalities. And I agree. If we can do oral medications, all of them together are going to be the best.
Yeah. So given that I have one of you in Canada and one of you in Michigan, and
The one in Michigan would like to be in Canada.
I don't know of anybody else that I would invite into this conversation that I would have as much respect for.
Aww.
So for the people that cannot see either of you, how do we help all of these people who are watching source what they need and speak in a way that they can get what they want.
And this is
But
where I have a lot of compassion for pet parents going to the internet. You know, we
if
roll
they
our
don't know
eyes.
what to ask,
Yeah, we roll our eyes and say, oh my gosh, don't go online. But what are they supposed to do? I agree. And then I say, find a good vet and have a connection with that vet and develop a good relationship. This is why I don't like, for people who can afford a veterinarian, I prefer a veterinary visit every year for vaccines that includes a wellness exam, because these are the things that we touch on, rather than going to a vaccine clinic or doing something like, you know, just in and out just for shots. But I also appreciate that there are a lot of veterinarians out there who might not be comfortable having that conversation, or they work for places that are like, listen, you have
but they don't know. So like
right,
Dr.
or you have
Serena,
15 minutes to do this appointment. You don't, like, 15 minutes is not enough to have a pain conversation.
right. So
So it's
Dr.
tough.
Serena and I were talking in the beginning. She was explaining in great detail. It was absolutely fascinating. Exactly.
That's her superpower, by the way.
Yes, I know. Her videos are like, I have to listen to them 5 or 6 times because they're so detailed and so smart that it takes me a while to absorb the information.
Mm-hmm.
So you got to dumb it down for some of us here.
That's my job.
No. She was explaining like how the things in the brain, the neurons work, and how the medications work, and how what the uptake means, and the synapses, and all of it. And it's like, oh, this is so cool. Like, we just don't know enough. You do, but the rest of us, we don't understand what we're looking at. We just want them to feel better.
It goes to the no, but I really appreciated a post that Dr. Serena made, because I have this conversation every day. It goes to, you don't know what you don't know. And I have pet parents come in after their dogs or cats have been on behavior medications for a year or two, and they're like, hey, things are better, I want to take them off. And we have the conversation of, okay, but if it doesn't work and we go back,
say, I didn't told you so.
It might not work the same the second time, because you're dealing with receptors that just might not respond the same way once we remove all of these things that are working. You don't just get to plug them back in. And you do have to have a certain understanding of how the chemistry is working to understand that, right?
It's very, very complicated. So like, Dr. Serena, when you were explaining about the like this fist and the space in between.
Oh, you guys talking about dopamine and serotonin? That sounds like a dopamine
about serotonin.
We were talking about serotonin, yeah.
Yeah.
And it was like, that made perfect sense. I thought it was like, oh, I sort of understand now. I feel a little bit smarter. So when you talk about all of that modeling, I think was the word that you used in the brain, right? And
remodeling.
I know I was going to get it wrong.
Your brain was just remodeled, Hillary. Your brain just had a little remodeling.
My brain needs a lot of remodeling. If we feel that the dog is on this stuff for a long period of time and we've done the behavior modification, we've sort of built the new neural pathways, there are new skill sets, new options, less. And I also love what you said in another one of your videos that I strongly agree with, which is that people need to understand that medications, I think I said this to a client yesterday, repeatedly, medications without behavior modification do shit. Medications without behavior modification will never do it. But if we dovetail those things and the dog now has all these other skills and they're getting better, if we start to scale back on the medications, what happens between these two guys?
This is all you. Mm-hmm.
Yeah.
Yeah.
So the first thing to kind of look at is ask the clients, are there going to be any major changes in the next 6 months? Are you moving? Is there going to be a baby? Are you traveling? Is the dog going to have to stay in a kennel? If there are going to be major changes, you do not want to touch those meds. Because if you touch the meds and then they go into a kenneling facility and 3 weeks later things fall apart, It's not going to be healthy for the dog. It's not going to be beneficial for the pet parent and those poor kennel staff.
Right.
And
But
so making sure that if we are going to wean, we have that conversation with the clients. The
okay.
receptors will remodel. And the hope is that they have built the ability to cope and the skills that they need to still remain under their emotional threshold, and not just the skills of the dog, but the skills
Yes,
of the
good point.
client.
Good point. Right. That the human has also learned new mechanisms to be able to communicate and work with that dog. That's an outstanding point that I think is not talked often enough about. It's always the dog, and it really needs to be both.
Yeah.
That work has to happen for both. But if we have the situation where the brain has modeled, no, I'm kidding, remodeled. I can't help it. It's been such a long week. And there's no major life changing events. Is there at some point, so once the brain has remodeled, how do I ask them? Once the brain has remodeled, is because there was, for lack of a better word, fragility at one point, is it more likely that that can happen again? Or is once this thing kind of rectified, it's less of a risk? Did that make sense? You could
Yeah,
say
so that
no.
a lot of it we can pull from human psychiatry is that anxiety, let's just use anxiety. Anxiety itself is adaptive. But how maladaptive is that individual's anxiety? How much does it affect their quality of life? If it's to the point where they can't sleep, they can't leave their house to walk down the street and back, that affects their quality of life. And so for each individual, it kind of depends. If
Right.
you have someone who's living in an apartment building in New York City, that's going to be very, very different than if
Yeah.
you live in a rural area where they can freely go out without seeing a lot of things that trigger them. And it has to do with the fact that our dogs have not co-evolved to meet our industrialization. They don't all have the ability to be resilient.
Right.
So we can't expect them to go to the point where they could be off of medication 100%.
So back to my question of learned skill versus how the brain functions and the support that it needs. Should we assume that if the struggle was there at one point, that it is more likely that there will be potential for struggle moving forward?
Depends on how intense.
If we take the training wheels off, yeah. Like how
Depends.
do those neurons work?
So the receptors will change if you remove the medications.
Okay.
But the neuron, like your new pathways, as long as we are not putting them over their emotional threshold,
Okay. Okay.
and because fear learning is very, very hard to reverse
Right. Right.
because it's adaptive. It is adaptive for us to be scared of things that hurt us. And that thing that could be hurting us is can also be potential and not even
Like the
rational.
anticipatory aspect of it.
That,
Right.
yeah, that's survival.
That's survival, and
Exactly.
they are animals. That's a really excellent point. Yeah.
And so if we are in an environment where we know that the pet won't go into a scenario that they can't handle, then we can wean them off the medication and rely on the new response pathways to those previously scary events.
In my experience, I'd be curious to see what you think, Dr. Serena. In my experience, it also takes a very specific human to maintain those pathways and have a structure in place where they're supporting that patient through it, because those pathways could be a little fragile as we're coming off of medication, and we want to make sure that the wheels don't fall off the bus. So that's also a part of my assessment. If I have someone who comes in and it's just that person and the dog, this is not their first pet, they've worked through it, they have a routine, then that seems to me like I could be successful in relying on the behavior modification. But if I have a really busy household and we're holding on by the skin on our teeth, like that is a different scenario. So that has to for me, that factors in too. Like, what's the environment? Not even just special occasions, like are we moving, are we traveling, things like that, but also what environment are we in and what support can this dog get or cat get when everything is gone?
Yeah.
Okay. Do you guys have questions that we haven't answered? It's Saturday night. I don't want to keep these ladies way too long.
It's Pandora's Hope. That's very sweet.
I don't want to leave anybody's questions out. I often forget to look at the chat and see what they're Would be interested to hear a comparison of separation anxiety versus other anxieties too. Well, I have thoughts on that, but I'll let them answer.
Separation anxiety is very, very often comorbid with noise phobia, noise anxiety, or noise aversion, however you want to call it.
Confinement anxiety too, right?
Yes. So as I said to Dr. Serena before you came on board, I happen to believe that when you see one form of anxiety, you are probably looking at a lot of different anxieties, because it is a nervous system panic response that becomes so well rehearsed and practiced that it becomes the response to everything. And so what we have to do is sort of relearn what it feels like not to panic, to be able to get past many of those responses in a number of different situations.
This is actually a really important point. This is kind of a passionate moment or point for me as a general practitioner in a general practice that is fear-free certified, because I think a lot of people think that if they go to their vet and their vet uses treats during the exam, that they're getting a fear-free experience and their pet is not experiencing stress and anxiety, and that they'll be fine year after year. And that is not the case, because their pet can be terrified and still be taking treats. We do use eating as a measure of the FAS scale, but I think it is important to your point, is there's a difference between coming to the vet and learning to be a part of the process and learning how to be at the vet, and that, they're how to expect what to happen, what a stethoscope is, what an otoscope is, and being okay with those things. And then there's just going in and being like, okay, well, I really like these treats, so I'm terrified and I'm just going to eat them all. So that's
FAS scale is fear and what's the
fear, anxiety, and stress.
And stress. So I will say that part of what was so interesting about this journey with the foster dog that I just had was what ended up transpiring behaviorally in the last week, and the reason that I ended up returning her, what I saw leading up to the final straw, for lack of a better word, is there was almost as if she was stopping herself from aggressing on me repeatedly, right? So the dog would run up to me as if she was going to bite me in the back of the legs, slide into, like she was sliding into first, get to me, freeze, and run away. And in my mind, I'm thinking, oh, good. Oh, you made such a good choice. You're not biting me. You're not aggressing on me. That's good girl, dog with a bite history. But the response became this loop of, I stopped myself, I'm over threshold, I'm hiding, and now we're in flight mode and not coming out. And that in and of itself almost became a trigger stacked situation. That loop of self-control ended up imploding.
Oh.
And that is when the deep belly growls and the baring of teeth, it was almost like I can't hold myself back anymore. And
We all know that. You spend all day minding your own business and like being kind to everybody, even though you're irritated about all the things, and then you come home and explode, right? Like we all know those. As human beings, we understand that.
right. No, but to your point about like give the dog a freaking cookie, you're actually building all the things that you're
Right.
trying to spare the dog from having to cope with. And I feel like we don't spend enough time talking about what does the world look like through the dog's eyes. I attended a conference a couple of years ago with some very prominent veterinary behaviorists. And I'm watching one of them, a name that you both know, which I won't, but I'm watching a video of this person meeting a dog for the first time. And their office is like a container, like one of those shipping containers that was kind of remodeled into an office. So it's really narrow and tight space, no room for the dog to get away. And they are moving towards the dog and offering it a cookie. And I'm thinking, you are a world-renowned veterinary. What the fuck are you doing right now? And the dog, I think, snapped at this person. And I'm like, I am not understanding what I'm looking at. Like from this side of the country and this side of the camera, I am watching you step up to this dog who is human-based fear and aggression with a cookie. And we're wondering why people have trouble getting good guidance, right? It's fascinating. That's just what people do with dogs, and we don't think enough about how the dog sees the experience.
No, absolutely. Absolutely.
I'm reading Inside of a Dog Mind now. It's an interesting book. Oh, okay. Yeah, I mean, that's the way to go, is through the dog's eyes, I think. But do we not answer anyone else's questions? Because I think we'll wrap up soon.
I would also like just to put a plug in for, I have a lot of conversations with people when we start behavior medications. They're like, oh my gosh, my dog is so sedate and he's sleeping and taking naps. And I'm like, your sense of normal when you live with a reactive dog is so skewed that when you finally have a normal dog, it seems really off. And so I think that's also an important part of the conversation for people to realize that mania is not just
not normal,
right? We have people who come in, they're like, my dog is so happy to be here. And I'm like, no, your dog is terrified right now. Like the mania is not happiness. The tail is wagging. Yeah, sure. All of those things. But like, no, your dog is actually terrified.
One last thing, Dr. Serena, you mentioned Cilio a little bit earlier. And I know that Dr. Forbes, you've mentioned Cilio gel. This is something that you can give a pet parent to give the dog to sort of sedate them prior to a visit. Are you using the gel as well, or Cilio for sound sensitivity? Is it that? Yeah.
Cilio is the gel. That's the brand. That's the brand name.
I use the horse gel though. I use the dextromethorphan horse gel.
It's Dotomidine. It's Dormocidin.
Yeah.
Is the horse labeled.
So it's the same.
So when I was talking about like extra label where like I'm going to use it in the dog, but it's labeled for a horse.
Okay. Gotcha.
Yep. So we have to have the conversation. This is extra label. Anytime we do something extra label, which by the way, almost all cat stuff is extra label, right? You have to have that conversation, but it's an easier delivery system to same class of drugs, but it's just easier and a little bit more potent the way we use it so that they can come in really sedate, which there again runs into its own issues, because if that pet is not sedate enough, year after year, they will actually start to get used to it and predict what's going to happen, and they won't be a
predictor of a bad experience. Yes. Yeah. We're conditioning them to the wrong thing.
Yep.
Yeah.
It's really tricky. It's not something that you can just like dabble in, and like it's complicated.
So let me ask you something, Dr. Serena, when you're working with clients, do you need a referral from a vet? Are you working virtually? Are you, because I know everybody here wants to be able to see one or both of you, and that's not easy for them, is it?
So legally,
Yeah,
I am allowed to practice within my licensed province. So I can't even practice throughout Canada.
interesting. Okay.
I
Close.
I have gotten some referrals from up north in the Yukon because they have different legal system when it comes to veterinarians.
Can you do a vet
Um,
to vet consult?
I can, yes, because then the prescribing falls under the primary care.
Hmm.
But I'm not offering that currently because I have my own goal to reach. And there's only so many hours in a day.
So when you work, if you work on a vet to vet consult, I could be wrong, but I would imagine that it might be really difficult for if I took my dog to the vet and I felt like my vet's not smart enough. I want to bring in somebody I think is really smart. How do we ask them to like meet with one of you to do without insulting them?
So, um,
Could you talk to this person? Because I really think they know what they're like. I wouldn't even know how to do it. Well,
That's a good way
yeah.
not to do it.
right, I know, but what would be the way to because like if you said to me vet to vet consult when I messaged you, and I thought, how the hell would you have that conversation?
So there are some of my colleagues who will do they call it a vet to vet, but the history and the behavior modification portion is directly to the client, and they'll be on a Zoom like this, and it'll be like they're talking to the client, then their primary care pops in. Here's the medication I recommend, and then they leave because they only have so many hours in their day. And like Dr. Forbes had said, if they have a 15-minute appointment, like
Right.
good luck trying to do
Anything,
everything
yeah.
that you need to.
Right.
That's where having an appropriate uh, dog behavior consultant or dog trainer um, that has a relationship with that veterinarian is very helpful
We're
because
screwed,
then
is basically where we're at. We're screwed as pet owners.
It's tricky right now. I'm
It's
not
tricky.
I don't think I can sugarcoat that. It's really tricky right now. You've got so many different forces, and in the US, I don't think this affects Canada, Dr. Serena, but we have the VPA bill that just passed, so that's going to add a layer of complexity to care.
is that the middle?
Yeah,
Yeah, okay.
the tiered care. Um So it is complicated. I think for the resourceful pet parent, I think there are ways to find resources. And if you have a good relationship with your vet, I think you can say, I love you. I love the care you provide. Is there anybody else? Would you be willing? Are there any other resources we can use together? And one of the key things to say, and I know this is difficult right now in this economy, but one of the key things to say to the primary care veterinarian is, I appreciate the relationship you and I have. It's important for you to be a part of that, and I will pay you
Yes,
to
yes, I
take
talk
the
about that all the
time,
time. Pay
right?
them.
I
You
will
don't
pay you
expect
to
people
take
to
the
do it for
time
free. Yeah.
to talk to this other resource. Is there anything else we can do? And I think that de-escalates the question when you start it by acknowledging how hard that primary care vet is working within their own confines of the practice they work for, but also their knowledge base. Like, I don't do oral surgery, so I don't have that conversation with anybody. I don't like anything in the mouth. I hate drool. It's disgusting. So everything in the mouth goes to somebody else. I can't. I
How do you
can't.
really feel?
Uh-huh.
How do you
Right?
really feel about it?
So I would never be offended if someone said, "Can we talk to somebody else who actually isn't grossed out by drool? Can we have a conversation?" Like, that's cool. I'm good with that. I also think it's finding someone that you have a good relationship with, because you should be able to say, like, if this is, if this is not your primary wheelhouse, can we reach out for a different resource? The other thing I want to say is it is unbelievably most emphatically important to do a complete physical workup on any behavior patient before we even discuss behavior medications. There is almost always a physical underlying issue that has led to the behavior, and then the behavior can become its own separate thing. It's like fatty liver.
We talked about this before you came on board because, Dr. Serena was talking about what her initial meetings look like and how thorough and detailed they are to address physicality.
And we'll do X-rays and ultrasound, and we'll talk about pain, and we'll do. I don't know if you're familiar with the Helsinki Index. I'll have clients do the Helsinki Index to get an objective pain score for dogs. You can use the feline grimace scale. I've been raked across the coals about suggesting using the feline grimace scale from one of the veterinarians who helped create it, because it's supposedly only for acute pain, but I kind of feel like in a cat, when do you know something is acute or chronic? So why not just use it and see what score you come up with?
That's true.
Right?
So, the other thing though is that if I feel that the seriousness of the behavior is intense and affects the quality of life of that pet, I do not withhold
absolutely
medications if I think that the pet would benefit from it.
Absolutely. Well, and they're going to need it anyway, even if we find the physical reason. In my experience, a lot of them still need the help with behavior medications because it's been going on so long that they need a reset. I just had a patient who came in for her recheck yesterday. Very reactive dog, very reactive to being on a leash, being in the window, people coming over, people outside, very reactive. She also happened to have a lot of GI issues, and we finally scoped her, and she has horrific IBD, and she has been on a treatment plan for that condition for about 6 weeks now, and her reactivity is almost gone.
Yeah. I've had dogs in the shelter who were incredibly violent and dangerous to handle. And I recall a purebred border collie who no one would take out because his kennel was always slathered in diarrhea. And so we had like 10 leashes put together that we would loop to the dog's collar, through the kennel door, and to the outside. And I would go in with rubber gloves because diarrhea. And I finally, after working with the dog and he was so willing to bite, finally I thought, wait a minute, why does the dog always have diarrhea? And I asked the clinic if we could get the dog on probiotics and gut health meds and all of that. And then I got him adopted pretty quickly. His behavior significantly improved when his belly didn't hurt, right? Like, we're all singing the same song.
That's amazing.
Yeah.
Oh, nice job. That's a good save. And
I should have come to that faster.
That poor dog. Can you imagine?
Horrible. I use Common Care. I think Dr. Forbes uses Visbiome, which is far more expensive, and it is a different bacterium.
I'll use both too. I'll use Common Care and Visbiome.
Do you have a probiotic that you love?
Me?
Yeah.
Oh. Over the counter, there's one that's called Love Bugs, and it's by Adored Beast.
Okay.
I think it's available in the States.
Adored Beast
it is. I've used it. Yeah, it is.
So the reason that I would choose that is because of the number of organisms that are in it. I have seen some pets that they have like disgusting flatulence and like stink up their exam room, and all I had to do was give them the probiotic and then that was gone. People don't realize that type of flatulence is not normal. And
your eyes are tearing up just talking about it.
And then ProViable is the vet labeled one that I reach for. but for the same reason, is that the gut biome is not a single organism. So yes, there's some research with the common care, but it is a single bacterial organism.
Right.
And the other thing is prebiotics, is to make sure that we're feeding the healthy bacteria what we want them to eat. And so if my diarrhea cases aren't already on a psyllium husk, they're on a psyllium husk.
Nutramax makes a ProViable with fiber that is really amazing.
Dr. Serena, someone's asking if you could mention I'm sorry, what does it say here? Conductor.
That's the first one.
Yes.
Love bugs.
The Adored Beast is
Love.
a company
Yeah.
that makes a lot of different products.
They do.
Someone loves the Nutramax fiber powder. It can be really fantastic.
Yeah.
Love bugs. I have to remember that one.
I had an interesting discovery when I was going through the cancer journey. Jude had MCT tumors, and the Clio protocol for the cancer diet, it included Benadryl daily, but it also was no fermented foods allowed, which I was surprised by, because it is inflammatory for histamine production. I don't know if I'm saying all of that medically correct, but you get the general idea. And no orange foods, no carrots, no pumpkin, no sweet potatoes, because that would, the fermented foods I was very surprised by, because we think of feed the gut. We want to give them fermented foods, but for cancer, or it's for MCT cancer anyway, it was advised that we do not do that.
Interesting.
Yeah, it was. That's what
I'm not familiar with that. That's really interesting.
Yeah. If a dog is allergic to chicken, does that translate to all poultry? I don't. No, turkey is okay for most dogs, but chicken is not. Is that right?
It can cross.
If a dog does not tolerate chicken, it does not mean the dog will not tolerate turkey.
But
Right,
it can.
that's what I said.
What's that, Dr. Serena?
But they can.
But it
Because it depends.
Right.
Right. And then they eat chicken organ meat, right? Like livers and things like that would not be the same as flesh.
Correct. But a lot of cross contamination.
Okay. Okay. And then, oops, Bagelish, I almost reported you by accident. If your dog's kibble includes a prebiotic, is there any increased benefit in adding more?
It depends on what the consistency of the stool is. Like if you got like a mucus coating on it, or it's like a little bit softer than it's supposed to be, then it would be beneficial, yes.
Okay.
You can also have too much fiber and the wrong kind of fiber depending on what's going on in the gut. So fiber is not always the answer without a diagnosis and someone helping you with determining whether or not it's large bowel or small bowel and what's going on with the kind of.
And if you're using psyllium husk, that's a grain, is it not? Is psyllium a grain?
Ooh, that's a good question.
I think it is.
I don't know.
Yeah. I don't know. I would totally be.
I didn't mean to.
Now I'm like,
That's a really good question.
It's a soluble fiber versus an insoluble fiber.
Right.
That doesn't mean it's not a grain though, right?
Right.
No.
Yeah, I don't know.
I think but that doesn't necessarily. So people think that grains are evil.
No, just inflammatory for some dogs.
For some.
Yes, for cancer, certain cancer, certain gut problems.
And grains themselves, however, are not all treated equal.
Hi, Alex, how are you? So I have been trying to, Dr. Forbes, I meant to ask you, and I haven't been able to get a hold of you. I want to upload the lives to my YouTube so people who missed them or came in late, and you and I had done one that everyone wanted to see, but I didn't want to upload it until I got permission.
Oh, absolutely. Yeah. Upload
Ask Dr.
away.
Serena. Yeah.
Yep.
So
I've
I
already
really,
come to terms with the fact that there's going to be some AI version of me in the future saying stupid stuff. That's fine.
yeah, me too, me too.
Right.
So yes, I'll be uploading the lives to my YouTube channel. So yes, you'll be able to
There we
Awesome.
watch
go.
if you
Some
missed
people
it.
have looked up
I'm
Celian.
so grateful to you both. Thank you
Thank
so
you.
much.
Thank you for letting me crash. I really appreciate it.
Don't thank me, thank her. Is my
We
link?
will
Yes, it is. It's linked.
we will do it again sometime.
I really hope we do, and maybe we can talk in a little more detail about behaviors and some of those, not just meds, but behavior and how we all kind of approach dealing with clients, and trying to just, I'm all about what can we do to help everybody because they don't know where to
Yeah.
go. My
No,
Well,
speckled
I think a
heart.
lot, the biggest one was like how do the pet parents advocate for their
Yeah.
pets? And to Dr. Forbes' comment is build a relationship with a vet that you can trust, and then you won't have to.
Right. So I don't know if you have this in Canada, but I every time I do a consultation with, which is usually all day long, but when I do a consultation with a new client, a big part, and I think I have this dog trainers university now where I'm training trainers how to do a consultation, how to build a business, and how to talk to people. There's so much that needs to happen in advance of the actual work. We don't just go into training. We have to build the foundation to begin all of that. And that includes having a relationship with a vet that you trust and you feel comfortable with. So I guide everybody, and I don't know if you have this in Canada, but in the States, we have an app called nextdoor.com. And that is it's like a neighborhood app where you can talk to your immediate surrounding neighbors or counties that are nearby, and you post, I'm searching for a vet that is savvy, a great diagnostician, preferably fear-free. My dog is complicated. Does anyone have somebody that they really feel confident in? And when you get 2 or 3 cross references for the same person, I don't care if you have to travel an hour and a half, that's where you're going. Because it's worth it to be able to, as you both said, communicate with your vet and actually feel heard, to be able to get to the place that you can to help your dog. Because we're just like, it's too far and I don't want to. Cut the crap. We don't have all that time to waste. We need to get to the good stuff. So, right? Like the misery is just, it's awful.
The Fear Free website has a lot of information too, and they have a vet locator. You can put in your zip code and find Fear Free professionals and Fear Free hospitals. There are 2 different things. So that's an option. And then the American
SAB.
What's that?
Yeah. The American Veterinary Society for Animal Behavior.
But I don't
Behavior
think that that's as
savvy.
good as a recommendation from people who go to those people. They don't all have good bedside manners. And
No, they don't. But it is a place to start. Because if a practice is fear-free certified, not a professional, I can't speak to the professional. But if an entire practice is fear-free certified, it says a lot about the culture, because the entire practice has to, like, everybody, there's a certain percentage of the people who have to be fear-free certified. They're coming in, they're reviewing all of the information. Right. So it's different than one person in the practice being certified. But if the whole practice is certified, that's saying a lot about how they're going to operate.
Excellent point. So that's not something that I was aware of.
And they
so
hold us
to look for the practice, not the practitioner.
Yes, and they hold us to really high standards. Like I can't.
Hi, Tracy.
Tilt it the other way. My white pale body will blind her eyes.
What did he say?
My husband just came in. He doesn't have a shirt on. He said, just tilt it the other way because my white pale body will blind everybody.
It's not his, mine.
So I do think that that's a reasonable place to go to. And then the American Animal Hospital Association also has a vet locator. Now that is going to be one where you're not necessarily going to click with the vet, but there again, they have certain standards that they have to maintain, and they have someone coming in and reviewing those every 3 years, and they have medical records. Like there's certain levels of standards that they have to maintain. So it's a place to start.
Yeah,
So
exactly.
that should be, go ahead. I'm sorry.
I was just gonna say that's like it's better than um, starting with your Google search.
Right.
Like, what's the
Fair
closest to
enough.
me? Just because the closest to you
Right.
is convenient, it doesn't
Right.
mean
Right.
that it's going to be the best.
Right.
Agreed. Yeah.
I have to tell you,
Time wasting.
Hillary, I'll be honest with you. I see the request for recommendations on Facebook or next door for a veterinarian, and my soul dies 1,000 deaths because Serena knows what, Dr. Serena, you know what I'm talking about. My soul dies 1,000 deaths because people don't always evaluate their experience at the vet based on a holistic experience. So they're not always like, sometimes they'll come in and say this vet was horrible and I had a horrible experience because they called at 5:59 on a Friday evening and had no money, and they were calling to say like, hey, my dog is lateral, can I bring them in? And we say no, you have to go to ER. Then we get a 1-star review because
No, but that's something different. So just in response, to be clear, my clients have had tremendous success sourcing a great vet by wording their posts very specifically. So what I'm asking them to do is use words like diagnostician, use words like
I like that.
Yeah, because when you put it out there in that way, then you get people who have been through it who are going to give you recommendations based on those things the criteria you're looking for, right?
That makes a big difference.
Yeah,
It does.
so
Because
I
exactly
agree.
that, like you need to be, some people think a vet is great because they're in and out in 10 minutes because they don't want to be there any longer than 10 minutes, right?
You're looking for something specific to find that you can talk to and have that relationship with, as you both described. I don't even use Facebook. I post on Facebook once or twice a year, right? Like a fundraiser for my brother's brain cancer and maybe something just to say, hi, I'm still alive. But generally speaking, I think Facebook is just a melting pot of bullshit. But if you're dealing with a local area and people have had good experiences, it's better than going on Google search and going in blind, right?
It is. Do you have a next door kind of fun thing in Canada?
I don't know. If we do, I haven't used it.
You don't need it, right? You're probably drowning in business to begin with, so that's not your problem.
I just also want to say that they don't have lepto in Canada, and I still can't get over that.
We do have lepto. It's just not here.
Oh, okay. You don't have lepto. Got it.
Because I practice in Ontario, which is right above Michigan. In Ontario, there was lepto. I diagnosed some cases there, but where I am currently, we don't.
I just can't envision a world without lepto. So
I'm sure it's going to come because we're getting an increase in raccoons.
Oh yeah, give it time. Yeah.
Mm-hmm.
The good stuff is coming. Okay. Well, I'm ready to go have dinner. Sitting here watching Dr. Forbes have her delicious meal.
Yeah.
Thank you both so much.
Thank you.
And thank you.
We'll have to do it again. Okay. And thank you, everybody who's joined us. It's been a wonderful way to spend a Saturday evening for me.
Absolutely. Thank you.
You want to reach out to me tomorrow to talk about the case? Okay.
Yeah, definitely.
Wonderful. Okay.
All right.
Good night, everybody. Thank you both. Bye-bye.